Welcome. In the previous session, we discussed the most common cause of orbital inflammation, that is thyroid orbitopathy. And in this session, we are going to discuss the remaining major forms of orbital inflammation. To recall, in any case of suspected orbital inflammation, we have to first exclude infection. Then look for a specific cause of orbital inflammation for which we may need to do a lab test and a biopsy. And the lab tests includes the thyroid function tests and the thyroid autoantibodies, and the other tests are directed towards the other specific causes of orbital inflammation. Biopsy is required in most cases of orbital inflammations apart from thyroid orbitopathy to look for a specific cause of orbital inflammation. And when lab tests and biopsy turn out to be negative, we make a diagnosis of NSOI or non-specific orbital inflammation, which is actually a diagnosis of exclusion. Vasculitis, which can cause orbital inflammation, include granulomatosis with polyangiitis, polyarteritis nodosa, and giant cell arteritis. Granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, is a systemic vasculitic disorder in which orbital involvement is the most common ophthalmic manifestation. 50% of GPA patients have orbital involvement, usually spreading from the sinuses. Most GPA patients with orbital involvement have limited form of GPA without involvement of the kidney and the lungs. And other ophthalmic involvement can be scleritis, sclerokeratitis, and retinal vasculitis. Orbital biopsy in a patient with GPA usually shows one or two components of the classic triad of vasculitis, granulomatous inflammation, and tissue necrosis. And serology reveals cytoplasmic pattern of anti-neutrophilic cytoplasmic antibody against the antiproteinase 3 antigen, which is highly specific for GPA. But C-ANCA antibodies is less commonly found with isolated orbital disease as compared to systemic GPA. And GPA, being a potentially fatal disease, requires aggressive treatment with induction with cyclophosphamide and maintenance of remission with antimetabolites. In polyarteritis nodosa, the most common ophthalmic involvement are intraocular with retinal and choroidal infarctions, and polyarteritis nodosa rarely involves the orbit. Giant cell arteritis we have discussed in the section on neuro-ophthalmology, and giant cell arteritis may involve orbital vessels also. Sarcoidosis can involve the orbit, and the most frequent orbital involvement in sarcoidosis is bilateral lacrimal gland inflammation. 7% of all sarcoidosis patients have palpable enlarged lacrimal glands, but 80% of all sarcoidosis patients show lacrimal gland inflammation in gallium scan. Less commonly, there can be conjunctival nodules, orbital involvement other than the lacrimal gland, extraocular muscle involvement, optic nerve involvement, spread from the adjacent sinuses, and nasolacrimal duct involvement with obstruction of the nasolacrimal duct. But extraocular orbital sarcoidosis and intraocular sarcoidosis rarely occur simultaneously. Biopsy can be taken from involved lacrimal glands and subconjunctival nodules, and management of sarcoidosis has been discussed in the uveitis section. IgG4 related disease or IgG4-RD is a systemic fibroinflammatory disease which involves the orbit, lymph nodes, lung, retroperitoneum, and the liver. And patients with IgG4-RD have elevated serum IgG4 as well as eosinophilia. Orbital involvement occurs in specific patterns in IgG4-RD, with lacrimal glands being the most commonly affected. In one pattern, there is enlargement of orbital nerves, mainly the infraorbital, which is a characteristic of IgG4-RD, associated with enlargement of the extraocular muscle and the enlargement of lacrimal gland, and this pattern is often associated with systemic involvement. Another pattern is a sclerosing dacroadenitis, and the third pattern is a sclerosing orbital inflammation without lacrimal gland involvement. Biopsy of involved tissues show lymphoplasmacytic infiltrates with IgG4 positive plasma cells. and there is an increased ratio of IgG4 to IgG plasma cells, and this increased ratio is important for diagnosis. We also find storiform fibrosis, which means whorl-like pattern of fibrosis, obliterative periphlebitis along with eosinophilic infiltration. Treatment is with steroids and immunosuppressives, particularly rituximab, which is an anti-CD20 antibody, and CD20 is present in B cell lineage. Relapse of IgG4-RD is common after treatment, and there is an increased risk of lymphoproliferative disorders. Sjogren syndrome presents with dry eye and dry mouth, and orbital inflammation of Sjogren syndrome involves the lacrimal glands, and the involved lacrimal glands can be swollen, normal or atrophic. Diagnosis is based on serology, in which we find SSA and SSB or anti-RHO and anti-LA antibodies, and minor salivary gland biopsy can also confirm the diagnosis. And patients with Sjogren syndrome has increased risk of non-Hodgkin's lymphoma. Non-specific orbital inflammation or NSOI is also known as orbital pseudotumor or idiopathic orbital inflammation, and it is a diagnosis of exclusion, which is very important to remember. And as we have mentioned, a diagnosis of NSOI is made only after specific causes of orbital inflammation have been ruled out, usually with a biopsy. And NSOI is considered to be an autoimmune inflammatory lesion because of its association with systemic inflammatory disorders such as rheumatoid arthritis, ankylosing spondylitis, myasthenia gravis, diabetes mellitus, and Crohn's disease. In NSOI, there is infiltration of the orbital tissues with pleomorphic inflammatory cells, including lymphocytes, plasma cells, and eosinophils with variable degrees of fibrosis. And there is a descending frequency of involvement of various orbital tissues. Most commonly, extraocular muscles are involved when it is called a myositis. Next, most frequently, lacrimal glands are involved in NSOI when it is called a dacryoadenitis. Then comes sclera when it is termed posterior scleritis. Next comes orbital apex when it is called a Tolosa-Hunt syndrome. And the least common pattern is a diffuse orbital inflammation in which all orbital contents are more or less equally involved. So here we have a patient showing muscle involvement, and here we have a patient showing lacrimal gland involvement more on the left side. Here we have a patient with a diffuse orbital inflammation of the right side, and this is following treatment. NSOI presents with either unilateral or bilateral orbital inflammation with deep orbital pain, proptosis, lid and conjunctival edema and erythema, and lacrimal gland swelling, and all these are features of orbital inflammation. However, lid and conjunctival signs may be minimal in patients with posterior orbital involvement near the orbital apex. With predominantly myositis, patients will complain of diplopia and pain on ocular movement, and on examination we will find muscle restriction. And with involvement of the orbital apex or the posterior sclera, patient will complain of loss of vision. In orbital apex involvement, there will also be numbness in V1 and V2 territories. V2 territory will be involved if the inflammation spreads to the cavernous sinus. And in NSOI, fever and sinusitis are uncommon, and this contrasts with orbital cellulitis, which almost always has fever and associated sinusitis, and this is very important to remember. Children with NSOI have more severe orbital inflammatory signs, and NSOI in children is more commonly bilateral. And children will more commonly have systemic symptoms of headache, vomiting and abdominal pain, and occasionally there can be fever as well. Children with NSOI can also have intraocular inflammation and associated peripheral eosinophilia. There is a sclerosing variety of NSOI where there is a predominance of fibrosis over inflammation, and these patients have minimal inflammatory signs including pain, and the predominant sign in these patients is restriction of ocular movement. and the findings on imaging depends on the type of orbital tissue involved in NSOI, and since orbital myositis is the most common form of NSOI, in most patients of NSOI we find muscle enlargement, and the muscle enlargement is up to the insertion of the muscle including the tendon. This is a very important differentiating feature from thyroid orbitopathy, in which characteristically the tendon is paired. So here we see enlargement of the muscle belly as well as enlargement of the tendon. We may also find increased density of orbital fat, thickening of the posterior sclera along with the tenon, involvement of the lacrimal gland as seen in this picture, but typically paranasal sinuses are not involved. We see the ethmoid sinuses and the maxillary sinuses are clear in these two images. In posterior scleritis form of NSOI, ultrasound B scan can show T sign. As mentioned previously, routine lab tests and biopsy needs to be done to rule out specific inflammatory causes of orbital inflammation. And orbital biopsy is recommended for all patients with orbital inflammation except those patients in whom predominantly orbital muscles are involved, which can be easily diagnosed by imaging, and in whom the orbital inflammation predominantly involves the orbital apex adjacent to the optic nerve, since in these patients there is significant risk of orbital biopsy. Treatment of NSOI is typically with oral steroids, and the predominantly inflammatory pattern of NSOI responds promptly to oral steroids. However, the sclerosing variety of NSOI responds poorly to oral steroids, and after the orbital inflammation starts to respond to the oral steroids should be tapered gradually. Since other specific causes of orbital inflammation as well as lymphoproliferative lesions also respond to oral steroids, orbital biopsy is recommended in almost all patients presenting with features of orbital inflammation, as we have mentioned. Sclerosing variety of NSOI usually requires immunosuppressives because they respond poorly to steroids. NSOI usually requires prolonged treatment with steroids or immunosuppressives, and recurrence of NSOI following treatment is also common. Thank you for listening.